It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preecish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
An 88-year-old gentleman with Alzheimer's disease, diagnosed with stage 3 cT2N2M0 esophageal adenocarcinoma. He originally presented with dysphagia, vomiting undigested food after meals, and weight loss for 3 months. His ECOG performance status is 3. His medical history is for Alzheimer's disease and hypertension. Social history is non-contributory, and his family history is non-contributory. Of last year, the barium swallow was negative, and he failed the H. pylori eradication therapy. In April of last year, he had a PET CT scan which demonstrated a large esophageal lesion, and the upper endoscopy revealed a 6-sided esophageal necrotic mass. Pathology was consistent with a poorly differentiated adenocarcinoma invading the muscularis propria. So, Dr. Siegel, can you please comment on what we're looking at here?
Sure, we're looking at axial and coronal fused images from an FDG PET study. And you can see on the left image, there's a large mass in a subcarinal location, which is the esophageal mass with markedly FDG avidity. And then on the coronal view, a similar large mass involving the mid-esophagus with marked FDG avidity. On these images that are provided, I do not see any markedly bright FDG avid adjacent or axillary lymph nodes.
Thank you. So we have this elderly gentleman here with a history of Alzheimer's disease and a performance status of 3 with this large mass, which is causing issues with weight loss and his ability to eat. So can you comment, Dr. Kubi, on this gentleman that I do not believe would be an ideal surgical candidate by any means with such a poor performance status, but can you please comment on how you would approach this patient?
Sure. The role for any kind of surgery in this particular patient is going to be small to non-existent. At 80, I mean, there are 88-year-olds who still ski, but this is not that patient in particular. So our role would probably be relegated more towards consideration of some type of feeding access versus just going with palliative care and no surgery at all.
Thank you. And Dr. Patel, this gentleman with this esophageal adenocarcinoma, do you have any input on how you would like to proceed with this patient if he was at your tumor board?
Yeah, thanks. I think, important for all of the team members to meet this patient and sort of try to get a handle on what sort of a level of aggressiveness is appropriate. It sounds like from the narrative that multimodality therapy is something that may be challenging for this patient. And in that case, certainly I think a referral to surgical oncology for feeding access would probably be the first thing we would do. As far as radiation is concerned, unfortunately, radiation alone is not associated with any long-term survivors. And so really, if we were to choose radiation alone, if for example, a systemic therapy is not recommended, In that case, I would choose, typically, again, a more modest dose. There is actually a randomized study from the TROG group looking at chemoradiation versus radiation alone for the management of malignant dysphagia. And there was not a benefit for chemoradiation over radiation alone for that particular endpoint. So in that case, I would choose usually a 2-week regimen, 30 gray and 10 fractions, if the team agrees that we're following a more palliative course.
And Dr. Benson, as you know, we do end up seeing these patients in our medical oncology clinic because they want our input, especially when there doesn't appear to be evidence of distant metastatic disease. What would you say would be in the patient's best interest at this time?
Well, I think we have to, with the spectrum of Alzheimer's disease, we need to understand where's the patient in that regard. Is his poor performance status on the basis of he's near end stage just from his Alzheimer's? But we certainly want to make sure we've given maximal supportive care, and bringing in palliative care would be important. It's important to discuss with the power of attorney, presumably he does have such, in terms of what the goals of care might be. There are, of course, Alzheimer's patients in the earlier phases of their disease where they're lucid and can make their own decisions to have that discussion. But if he's really declining and the Alzheimer's is a significant problem, I guess one thing I would ask is if stenting was feasible, because that might give the patient the temporary relief he needs. And, without such, he still could have problems handling his secretions and so forth and run the risk of aspiration. So I would ask, is stenting feasible? And if his performance status was such that that could be improved, I would favor the briefest amount of intervention possible. So chemoradiation might be, an attractive option if his performance status improved. But it might be if he could be stented and people felt that no further intervention was appropriate for this individual, then stenting may keep him more comfortable.
And Dr. Benson, Dr. Eng, thank you. I'll comment on that. Probably should have brought that up as an option. I don't do the stenting personally. I work closely with my thoracic surgery team and my GI team who would consider it. And certainly if they could get a wire across the lesion, then that's where you would have the discussion about a stent. A stent would relegate the patient pretty much to a liquid diet still, but that's better where the patient is right now. So that's an excellent point. Thank you for bringing that up.